everyone, and thank you all for joining us today. On behalf of the Radiologia Society of Rio de Janeiro and OCAD, I want to welcome and thank you all. My name is Aline Sirfari, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. And our guest speakers today are Drs. Graeme Thompson, Juan Pablo Muñoz, Darra Murphy, and Tatiane Cantrelli. This session will focus on sports imaging, and the speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is OCADMSK.com, and on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. A quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speakers is illegal. We thank you for your understanding. And with that, please, Hilary, kick off the session.
Okay, welcome everybody. I want to extend a special welcome to our friends Catherine, Natalia, and Marina from the Ukraine. And now it's my pleasure to introduce my friend, Dr. Graeme Thompson, who's a consultant musculoskeletal radiologist with Oxford University Hospital and Oxford Musculoskeletal Radiology in the UK. He's originally from Cape Town, South Africa, where his interest in sports radiology led him to perform imaging on local and international cricket and rugby players, as well as other less important athletes. He is a member of the sports committee of the ESSR and has co-authored chapters in their sports imaging series of books and has published articles in skeletal radiology. He's given lectures on sports injuries at the ISS, ESSR, BSSR, Erasmus MRI course, and South African Sports Medicine Congress. He's married with 3 children, and his sports record is quite impressive, including a first division rugby and endurance triathlon, having completed 3 full and 8 half Ironman races. Okay.
Thanks, Hilary. That's a very nice welcome. Hopefully the 10 minutes is something I should be able to manage after all that endurance training. I'm just going to share my screen here. I assume that's what I have to do. Here we go. Right, let's get going. Can everyone see all right?
Yes.
Okay, brilliant. Thank you very much, Hilary, for the introduction, and thanks everyone for joining us. Welcome to Friday afternoon and the weekend. So the case that I want to present to you today is a 14-year-old water polo player who presented to us with a clinical suspicion of a slap tear, primarily because they were unable to throw. In addition to water polo, they played cricket and weren't able to throw in from the boundary. They also had a tight posterior capsule, which is a common finding with throwing athletes. Totally normal X-ray, and then they were referred to us for MRI. I want to draw your attention first to the normal study on a patient of a similar age, demonstrating the insertion of the subscapularis tendon, this very thin, hyperintense bit of tuberosity cartilage. So this is almost a completely ossified tuberosity, and we'll look at that process in a moment. On the abnormal, on the athlete's MRI, what we noticed was this hyperintense cleft between a bit of tuberosity cartilage and the subscap tendon, not completely separated, but a definite irregular cleft with a bit of fluid in it. And on the coronal images, you could see a slightly retracted periosteum and something that is partially detached from the tuberosity. And the diagnosis at the time was made of subscapularis avulsion with a small cartilaginous component of the tuberosity with it. But because it wasn't particularly retracted, the patient was treated conservatively. And after conservative management for 3 months, we scanned the patient again. But at this stage, there's now fluid going all the way through. It's still not healed. And in addition to that, you're starting to see some ossification of that cartilage of the tuberosity on CT as well, and progressed from the original MRI to the current one. There's increased ossification in that detached cartilage. So the patient was still symptomatic. This hadn't healed, and the orthopedic surgeon elected to put the screws in. This is a study from 3 years later, when most of these water polo players are also rugby players. It's an off-season sport for rugby players. It's got a bit of contact in it, so they enjoy it. But at 3 years later, you've got a healed tuberosity, and what I'm not showing you is also a Bankart lesion. So these kids have pretty messed up shoulders with that combination of sport. This was another polo player, this one 13-year-old, and here there was chronic shoulder pain with no real history of specific trauma, and pain with resisted subscapularis contraction. This is a lot more subtle. All we see here, there's your subscap insertion, the perichondrium, and then this very subtle cleft. We tried internally rotating the arm to see if there'd be any difference there, and really there's no change at all. Some subtle changes on the T1, but I just draw your attention to the axillary view here, the axial view. This very faint little cortical flake is all you really see, and it really is only the axial view that shows these things if they are going to be visible on X-ray. This is more obvious. This is a rugby player with a rugby-specific injury, acute injury, with a weak and painful subscap. And in this situation, what you're dealing with is a more obvious avulsion of a portion of the tuberosity with a fluid separation and slight retraction. And that's really the same pathology, avulsion of the lesser tuberosity apophysis by the subscapularis tendon. So let's just look briefly at some anatomy behind this. We know that the ossification centers in the humeral head they're 2 in number, one for the greater tuberosity and one for the humeral head. They gradually fuse together and expand in size. So when it comes to the lesser tuberosity, this is quite a wide insertion of subscap with muscle insertion more inferiorly, and then the footplate for the tendon more superiorly. But the lesser tuberosity, rather than developing an ossification center of its own, the humeral head ossification center simply expands to fill in the space. So I'll show you here, this is a collection of images that I've taken from various ages, starting off where you've got this hyper-intense cartilage, apophyseal cartilage. You've got the ossification center of the head and of the tuberosity, and the subscap tendon insertion. And then as you get a little bit older, you now got just a very thin strip, hyper-intense strip there, getting smaller to about this patient's age, where you've got this very thin rim of cartilage. What you've got over the cartilage is perichondrium, which is hypo-intense, and of course the fibrocartilaginous attachment of the tendon. By the time they're 17, that's completely gone, the cartilage completely ossified with a normal tendon enthesis. So what happens with these adolescent water polo players, and of course I mentioned they do other things, they also may often play other sports, rugby or cricket. But in water polo, you get quite a wide variety of injuries because you've got a swimming athlete, so they get impingement, they get rotator cuff problems. They're a throwing athlete, so they get problems with micro instability. And then, of course, there's also trauma involved, so you can have acute injuries. So in the acute situation, you might have eccentric loading from the ball, or an abduction, external rotation injury like you get in rugby. In polo, you may get blocked with your shot. And then chronic repetitive injuries, which we've seen in our cases here. And that happens also in baseball and at batters, interestingly enough. And then in fly fishing, which I found quite surprising, being a fly fisherman myself, fortunately never got that. But I guess that's from the loading of the line behind you. The reason why it happens in water polo, the shot isn't as fast as it is in baseball, but you've got a ball that weighs about 0.5 kilo and you don't have the fixed lower body in order to give you that extra force from the lower body. So there's a lot of force involved. These injuries aren't common, so they're often not diagnosed properly, particularly as they aren't visible on X-ray. So they have the doctors have to be aware about patients who have weakness on internal rotation, who have a positive liftoff test for the subscap. Possibly an axial X-ray will show it, but it's not really that super reliable. But MRI is obviously the crunch when we look at these. And the reason we want to diagnose it is because there's good arthroscopic techniques now in order to take, this is the defect on the tuberosity, there's the cartilage, place the sutures, and then you can tack it back down in place and treat these patients so they can get back to sport and back to their sporting career. Just to add this one in, to make a point, this is another water polo acute injury. This is a GLAD lesion. There's on this ABA, you've got a detached labrum and a cartilage defect. But the interesting part of this one is that here in front of subscap, there's actually an ossicle, which turns out to be the avulsed and separated tip of the coracoid process. This is another, this is a water polo player here, where we've got a tuberosity, where you've got a coracoid stress fracture. That's not the epiphysis, it's that it fused already. But just to make the point that because they're throwing athletes, because there are unusual forces involved, there are some unusual injuries in addition to the tuberosity avulsion. You may see things like a coracoid stress fracture that itself may relate to the micro instability that one sees in a throwing athlete. So you just need to be aware of some of these other potential injuries. In summary, in dealing with these patients, whether they with these sports people, be aware that it happens in water polo as well as acutely in sport, contact sports. Have a high index of suspicion for the signs, the subscapularis signs. As I said, axial X-ray, you can see it, not super useful, but really it's MRI and then early surgery in order to get these athletes back on their feet. Thank you very much.
Thank you. Now it's my distinct pleasure to introduce my dear friend, Tatiane Cantrelli. She's a practicing musculoskeletal radiologist at HCOR and Teleimagem in São Paulo, Brazil, where she trained during her clinical musculoskeletal fellowship. She's also a former research fellow at NYU and a member of several radiology societies in Brazil. She has authored and co-authored articles on MSK field, and she is a very active MSK educator, lecturing in several Brazilian and international meetings. Please, Tatiane, share your screen.
Are you seeing my screen?
Yeah.
Okay, thank you. Today I'll be presenting two cases of the same pathology in this sports image session. Let's begin. So the first case, it's about a 45-year-old woman who is an amateur beach tennis player. And I have to mention that beach tennis has become a phenomenon in Brazil. There's a beach tennis court in every corner of São Paulo. And in this case, the patient presented with complaints of pain and swelling in her great toe after hyperplantar flexion during a match. And the primary concern was to rule out a ligament injury. So the patient underwent an MRI. There is no X-rays. So on long axis MRI image was observed that was soft tissue swelling, predominantly located dorsal to the first interphalangeal joint. However, the collateral ligaments of both the first interphalangeal joint and the metatarsophalangeal joints were found to be intact. And now let's focus on the extensor mechanism of the first toe. Remember, there's two tendons, the extensor hallux longus, this red one pointed here, and the brevis, this yellow one, the smallest one here. So on short axis MRI image, we can see the extensor hallux longus and the extensor hallux brevis at the dorsal aspect of the great toe. So the extensor brevis tendon runs in a medial oblique direction. So we can see here, going to medial, and insert to the dorsal capsule at the dorsal base of the proximal phalanx of the toe, about this level. And the extensor longus tendon, this one, the structures here, has a long distal tendinous insertion at the dorsal base of the distal phalanx of the great toe. And when we follow the tendon until the base, we can see there is a cortical irregularity of the bone of the distal phalanx with the continuity of the tendon. And also there is soft tissue swelling surrounding bone marrow edema. On sagittal fluid sensitive sequence at the level of the great toe, there is an evidence of an avulsion fracture here, pointed out by this yellow arrow. These fractures extend to the interphalangeal joint of the hallux with bone marrow edema and again soft tissue swellings, and involve less than 1/3 of the articular surface. It's important to note that the extensor hallux longus tendon remains intact, this black structure here, and still attached to the avulsed bone fragment pointed by this red arrow here. Now the second case, this one's about a 69-year-old man present with complaint of pain and swelling in his great toe following direct trauma. He stubbed his great toe, causing hyperplantar flexion of the interphalangeal joint of the hallux, and the image was to rule out fracture. So on X-rays at the base of the distal phalanx of the great toe, here we can see a cortical irregularity, but it's not easy to say that's a fracture. On the lateral view, despite the multiple superimposed structures, this is too difficult, but you can see a small bone fragment here at the dorsal aspect of the distal phalanx. And seems to not to be a significant articular involvement. And on the morai at the sagittal planes, there is evidence of a small bone fragment here. You can see here again with bone marrow edema. And again, the extensor hallux longus tendons appears to be intact, it attached to the bone fragment. So what was the diagnosis in both cases? So in both cases, it was diagnosed as a mallet injury of the great toe. So hallux mallet injury. So these lesions that could be traumatic and can occur in adults and in children. It can be a result of direct trauma, as the second case, when the second patient, or a avulsion injury, as we saw at the first case. And it's a condition characterized by abnormal flexion deformity of the toe joint, causing the toe to bend downward at the distal interphalangeal joint, or when we're talking about the hallux, only the interphalangeal joint. So these conditions can be classified in two different types. If it's a closed injury, and also can be classified as an open injury. When closed, we can see, we need to see if there's a fracture or no. And there are three types: when we have a small dorsal avulsion fracture, when the bone fragment involves the articular surface, and if it's a distal phalanx physio injury in pediatric patients. Here we have on a pediatric patient. This is a CT scan of a 13-year-old boy present to the emergency department with swelling and pain of his big toe following trauma during a soccer match. So this is a fracture line in the physis. Here we can see the enlargement and the irregularity, some small bone fragments. The epiphysis is displaced. There is a discontinuity here at the physio plate. So this was classified as a Salter-Harris type 2 injury. Even in a CT scan, we still can see the tendon here, the extensor longus of the hallux attached to the bone fragment in this sagittal reconstruction. This is another pediatric case from the literature. So it's a case of a traumatic avulsion fracture of the distal phalanx of the hallux, also in a 13-year-old patient. In this case, the patient had a Salter-Harris type 3 fracture of the distal phalanx with articular involvement, and the patient was treated non-operatively for 6 weeks, as you can see here, with an excellent outcome. So a review of the literature, this study revealed only 10 reported cases of hallux mallet injuries, with the majority being bone injuries affecting middle-age groups, and happen as a result of a severe hyperplantar flexion injury, as we can see in all the cases that I present. So there is no consensus for the mallet toe injuries, so what we need to report when we saw these injuries. But for the mallet finger, the percentage of articular surface involvement on X-ray must be reported because bone fragments with greater than 1/3 involvement of the articular surface may require fixations. And maybe we need also to report this as well when you are dealing with toe or hallux mallet injuries. I said there's not much literature on the treatment of the mallet toe of the hallux, since it's a rare lesion, and there is no consensus on the treatment, but surgical and non-surgical options of the mallet finger have been well described, and this may be applied to the hallux since the thumb and the hallux have similar anatomy. And some treatments consist in tendon on bone or bone fragment reinsertion. And prior to 2001, cases were primarily treated with splints due to the lack of surgical literature. So these are some reference, and thank you.
I love toe injuries. Thank you.
I know.
Oh, I'm sitting here in the dark. Maybe I can fix that. I don't know how to do that. Okay, now I get to introduce Dr. Darra Murphy, who's a musculoskeletal radiologist working in St. James Hospital, Dublin, Ireland. He previously spent 10 years working in Vancouver, BC, Canada, including completing an MSK fellowship in Vancouver General Hospital, followed by 8 years working in St. Paul's Hospital in Vancouver. He returned to his native Ireland almost 2 years ago and now lives in Dublin with his wife and 4 children, as well as being an MSK imager and interventionalist. Dr. Murphy also specializes in cardiothoracic imaging. Okay, Darra, share your screen.
Okay, thank you. And let me just go to okay, that's sharing okay, Hillary? And you can hear me, great. Okay, fantastic. So I just have one case to present today, and the case that I have is a case of a 42-year-old woman. She's a recreational runner, and she has anterior knee pain, and she was referred into us for an MRI of her knee. And so I'm going to scroll through some sagittal, and then some coronal, and then some axial images, starting from sagittal PD sequence. From the lateral side to the medial side. And I want you to pay attention in particular to the anterior part of the knee, starting from the lateral side and moving medially. And you'll see that the patellar tendon has an unusual morphology. Now, she also has a lot of patellofemoral arthritis, which we can see with joint space narrowing, some periarticular osteophytes. But then we follow that sort of double appearance of the patellar tendon as it inserts onto the tibial tuberosity. And the rest of the knee is pretty unremarkable. The ACL and PCL are normal, the menisci are intact. There's a little bit of cartilage change, but not much. And as we come on to the coronal imaging, you'll see again that sort of crossed appearance of the patellar tendon. Again, she's got that patellofemoral arthritis, which we can see a little bit of meniscal and cartilage damage, some edema in the medial side. And then the axial images, again, showing lateral subluxation of the patella with these prominent patellofemoral osteophytes, a small joint effusion, lots of cartilage loss in this relatively young woman. And then as we look at the patellar tendon, we see this crossed appearance of the patellar tendon, where the lateral portion goes deep to the medial portion. And as we follow it down more inferiorly, we see them both inserting onto the tibial tuberosity. Now, there's no micrometallic artifact to suggest that there's been previous surgery. But that certainly did cross our minds. And so how can we think about variance in the knee? And there's been a couple of really nice papers looking at variance in the knee. This is a nice one from a couple of years ago, relatively obscure journal, but it's actually a very nice very nice paper, and it goes through lots of variants, but actually a lot of them are limited to things like the menisci, the ACL and PCL, and some of the tendon insertions, but there's no mention of the patellar tendon in this particular paper. So I kept searching, and I found another nice paper from Skeletal Radiology, a bit more recent, 2018. Again, lots of normal variants described in the anterior knee with diagnostic pitfalls, but again, no mention of sort of a abnormal variant of the patellar tendon that might be similar to this. Lots about plique and fat pads, but nothing about patellar across patellar tendon. So we kept looking, and then Ricken Harganani from the UK, one of my favorite MSK radiologists, we crossed paths in Vancouver when he was finishing and I was starting, and Ricken and his colleagues published a very nice paper quite recently, only a couple of years ago, a 46-year-old woman who had an appearance of a double patellar tendon, but it wasn't crossed. If you look at the imaging from this, again, beautiful images that they provided, where they show definitely a double appearance to the patellar tendon with a deep and superficial component, both of which are separated by a fat plane, but they weren't crossed over. So they run in parallel to each other, and they insert together on the tibial tuberosity. So that was one thing that crossed our mind. Was this a potential, a normal variant of a double patellar tendon? So then we keep going, and then there's another paper that I found, and this is from 2016, and this is a double cross patellar tendon. And they ask, is this an atavistic variant, a very unusual term, a simple mutation or a pathologic finding? And so in this paper, they have, again, a young woman who's in her 30s, and she has this appearance, very similar to ours, where they have a double cross patellar tendon appearance. And again, there's no sign of any patellofemoral arthritis in this case. There's they've done a gradient echo sequence again with no signs of any surgical intervention, and she denies any surgical history. Although, of the patellar tendon. Although there is a report there were mentioned in the report of 2 previous surgeries to that knee to remove a hemangioma, and judging on the timing of what they report, they were probably done when she was kind of early childhood, maybe 8 and 13. These 2 different operations, 5 years apart, to remove, as they say, a hemangioma around the knee, but they don't describe exactly much more detail about that. So she definitely had surgery. The axial images, again, looking very, very similar to ours, where the lateral portion of the patellar tendon tucks in underneath the medial portion and then inserts onto the tibial tuberosity. So why am I showing you an emu? This crossed my mind because only a few weeks ago I was at the zoo with my kids, and we're feeding these emus. The emus have very small brains. For their large bodies, so they're not very clever birds. But in this article that they described, the emu has this very similar appearance of a double-crossed patellar tendon, and so there was some consideration: is there some historic, going way back, similarities between human and large bird knees? I think that's possibly unlikely, but it is interesting to note that that there are some animals out there that have a double crossed patellar tendon. A subsequent paper again showed a very similar case. Again, this is more recent again, and this is the second published paper of this, of showing this cross patellar tendon. But in this case, the patellofemoral joint is really arthritic. This is a 70-year-old guy, very similar to ours, very arthritic patellofemoral joint. And again, no history of surgery in this patient. One of the nicest papers about the anterior knee is looking at normal anatomy and disorders with anterior knee pain by Diane Flores, who spent a year with us doing a fellowship. And probably I learned more from Diane. I certainly learned more from her than she learned from me, that's for sure, in the year. She writes amazing papers and with lovely graphics. And again, this is a really nice paper. They go into a fair bit of detail about patellar maltracking, which is very interesting in terms of different osseous soft tissue and various stabilizers on patellar side, trochlear side, and the measurements that you can do. And it's a great article. So that kind of got me thinking. So like any good radiologist, went back to look at this latest plane films. And the most recent X-ray didn't show any surgical hardware. There's no screws or anything like that. So we went back to another previous X-ray, and sure enough, we have bilateral knee X-rays from a few years previously, and she has a dirty big screw in her right tibial tubercle. So she's clearly had some previous surgery to the right side, and probably correcting a patellar maltracking disorder. So in this case, this was a post-surgical case and not an anatomic variant. based on the fact that she has the history of the surgery. And so when we talk about patellar maltracking, there's a few main factors in stability of the patellofemoral joint, including the medial patellofemoral ligament, lateral retinacular integrity, the trochlear groove, vertical patellar positioning, patellar tendon length. And when we think about the passive restraints, the MPFL is a primary passive restraint in the first 20 degrees of knee flexion. And the trochlear groove accounts for stability in deeper knee flexion after the patella begins to engage the trochlea at about 30 degrees of flexion. Patellar height also plays a role in stability, allowing for appropriate engagement within the trochlear groove. And then in addition to variations in the above described anatomy, there are generalized ligamentous laxity, increased Q angle, and trochlear dysplasia, which are recognized risk factors for patellofemoral impingement. And then excessive lateral patellar tilt by the IT band and by the lateral retinaculum contractures and lateral femoral condyle hypoplasia can also impact tracking and stability of the patella. So patellofemoral impingement is caused by both proximal and distal pathoanatomic alterations. And distally, a large tibial tubercle to trochlear groove distance, or TG distance, signifies a larger quadriceps vector or Q angle, and then greater lateral displacement force on the patella during knee motion. And with a TG of more than 20 millimeters, it is an indication for a surgical intervention. And surgical intervention basically depends on whether the patient is skeletally immature or skeletally mature. Obviously, threatening the physis or interrupting the physis is a problem. So tibial tubercle osteotomy and realignment is an option, but you've got to be very careful that the physis doesn't get interrupted. In terms of proximal realignment, there's things like MPFL, reconstruction or repair. There's medial imbrication, vastus medialis oblique advancement. And then distal realignment, there's things like a Galeazzi tenodesis. There's a patellar tendon shortening procedure that can be done, or a Graeme procedure. And finally, the Roux-Goldthwait procedure, which corrects an increased Q angle, similar to a tibial tubercle osteotomy, but without threatening the physis. So this is what this looks like, and this is from the original paper in 1904 from Goldthwait, who is a surgeon in Boston. And what they do is they get a scalpel to divide the patellar tendon longitudinally. The lateral half then is subperiosteally dissected off the tibial tubercle and passed deep to the medial half of the tendon. Sutures are placed securing the transferred tendon onto the pes and surround after an L split. And that's just a graphical representation of that. The advantages and disadvantages are shown in this table, which is taken from another paper. And again, this shows a very nice kind of representation of what are the good and bad things of doing a Roux-Goldthwait procedure. But the disadvantages are a large anterior scar, which I guess in those two cases in the case reports, you would expect a very obvious anterior scar if these were indeed post-surgical cases, and they don't describe that. So back to our case, this is Goldthwait himself. As I said, he was a surgeon in Boston in the early 1900s. Did a lot of surgery on war veterans, but his main interest was in patellofemoral disease. And so, what would he make of our case? I think that this is almost certainly a post-surgical case. The other cases in the literature, we see commonly patellar maltracking in sports imaging world. We don't often see the post-surgical complications. It often presents acutely in a setting of a transient patellar dislocation, which we see commonly. And normal variants in the knee are very common, but beware normal variants and beware post-surgical findings that could alter your diagnosis. The patellar tendon is obviously a very useful tendon for lots of, especially for ACL reconstruction. So it's a very important tendon to be aware of and to describe accurately. So that's with that, I'll pass it back to you, Hilary, and ready for the last case presentation.
Thank you, Darra.
Aline.
Our next speaker is Dr. Juan Pablo Muñoz. He's a consultant musculoskeletal radiologist at Med Sports Clinic, an MSK radiologist at Hospital Clínico Félix Buns in Santiago, Chile, and part of the radiologist staff for Colo-Colo professional Chilean football team. He graduated with a degree in medicine from Universidade Maior, a medical residency in radiology and diagnostic imaging at the same institution, and a fellowship in MSK radiology at Pontifícia Universidade Católica. He's a member of the Radiological Society of Chile, and he's a very active MSK educator with popular MSK accounts on social media, having lectured in several Chilean radiology and orthopedic meetings. Please, Juan Pablo, share your screen. I can't hear you. Juan Pablo, you're muted.
Can you hear me now?
Yeah, I can hear you now.
Okay, I wasn't allowed to activate it.
It's not on presenter mode, just so you know.
Okay, that's it.
Oh, now it's good. Thank you.
Okay, thank you. Well, let me say, I'm really excited to be a part of this great initiative. Special thanks to Aline Serfari for reaching out and inviting me to participate today. So, mucho obrigado, Aline. I'll start with my case. This is a 25-year-old male, right-handed rock climber, and he presented to the hand surgeon's consult with medial hand pain after sports climbing during the weekend. After initial clinical assessment, an ultrasound was ordered to rule out pulley injuries. This is the volar aspect of the ring finger. At the top, we can see mild tenosynovitis and ill-defined and lobulated contours of the A2 pulley. There seems to be as well a separation between the volar cortex of the proximal phalanx and the flexor tendons. At the bottom image, we can see diffuse hyperemia of the soft tissues on the Doppler ultrasound. We frequently send back to our surgeons comparative images of subtle findings to make it easier for them to see. And this is the case. We can appreciate that the separation between tendon and cortex becomes more evident once we see the normal side next to it. Now let's go through these images from a learning perspective. We can see this soft tissue overlaying the flexor tendons that corresponds to the mostly torn A2 pulley. In this close-up, it's easier to see as well the separation between tendon and cortex due to bowstringing. So these findings are consistent with an A2 pulley injury. That, as previously mentioned, becomes more conspicuous once we see the normal side with its intact A2 pulley for comparison purposes. But I'm not here to talk about pulley injuries. You've probably seen plenty of those, and they are very well documented on radiologic literature. So before I dismissed the patient, I wanted to make sure we had no ancillary findings. So I got a full scan of the flexor tendons, but found no primary tendon injury. I am confident now with my call, but before the patient leaves, he tells me that his trigger point is not his ring finger, but rather his hypothenar eminence. So of course I take a look, and what I found is actually already on screen. I am now going to overlay the flexor tendons of both ring fingers to give you some anatomical reference. If you look to the left hand, you'll see that the flexor tendons are fully surrounded by mostly hypoechogenic muscle bellies, as is the case of lumbrical. If we go back to the right injured side, we'll see that on the radial aspect of the ring finger, there is diffusely enlarged and markedly echogenic muscle belly that corresponds as well to the third lumbrical. Now, if I remove this diagram, you can fully appreciate how asymmetric these muscle bellies have become. Frequently, axial imaging may be hard to tell on ultrasound due to anisotropy. That is why I'm showing you now the longitudinal scan of that muscle belly. And we can see that it's in fact diffusely enlarged and markedly echogenic. Once again, easier to spot once we see the normal side next to it. So this patient had not only sustained an A2 pulley injury, but a third lumbrical muscle tear as well. A rare injury, but this is a high-performance athlete, so he's prone to get injured in unusual places. We see this all the time with pectineus and obturator tears in pro soccer players. So at the time, I didn't read much into this and I moved on. A couple months go by and an identical patient walks in. Also male, mid-20s, right-handed rock climber. And once again, the request was to rule out pulley injuries. But on this occasion, his pulleys were intact. As I was prepared, I immediately scanned his hypothenar eminence. And this is what I found, but this time centered over the fourth lumbrical. And if you look between the red arrows, you can see this lumbrical is diffusely enlarged and markedly heterogeneous along the entire scan. I am now going to show you the normal side to make these findings stand out. If you please look to the left side between the green arrows, you can appreciate how slim the fourth lumbrical really is and how homogeneous it is along its entire length. Now, if we go back to the right injured side, we'll see how enlarged and heterogeneous this muscle belly has become. Once again, associated with diffuse hyperemia of the soft tissues on the Doppler ultrasound interrogation. So to sum up, in these last few slides, I've shown you muscle injuries of the third and fourth lumbrical muscles, but not the first two. And this is not random. This is highly specific for any type of climbing activities. And all of this can be explained by what is known as the quadriga effect. Let's look into this. So what is a quadriga? It is an ancient vehicle used in Rome and Greece with 4 horses but a single rider. So the connection between these 4 horses is what makes the analogy with the flexor apparatus. Let's see how this works. This is a beautiful macro section from the Journal of Hand Surgery. This is not mine, so I'll leave the QR for this picture in the right bottom corner. And here we have the flexor digitorum profundus of each finger with the flexor digitorum superficialis and muscle bellies removed. On the radial aspect, of course, we have the flexor pollicis longus that we are not going to worry about right now, but rather focus our attention on the remaining 4 medial fingers. Let's take a closer look at the carpal tunnel level. At a first glance, what we see is what classic anatomy teaches us. That is, 4 main tendons going from the wrist to the fingers. But this is a simplification of what's really going on, because there are several connection points between flexor tendons that we should be aware of. First, let's look at these thick webs of connective tissue bridging one tendon to another, our first connection site. Now, look at these actual threads of tendons, switching lanes going from one tendon to another. In this case, from the middle to the ring finger. We can see this happening over here and over here as well, our second connection site. This is very well known by hand surgeons, and this is what they call the quadriga effect, but they use it to explain a different phenomenon. Once they've operated on a flexor tendon and the finger next to it develops flexion malfunction. But the quadriga effect does not end here. There's more to it at a more distal level, on account of the lumbrical muscles. Let's take a closer look. So lumbrical muscles are a very unique set of muscles in many ways. First, they do not have bony attachments. They go from the flexor tendons to the extensor aponeurosis. Let's take a look at this third lumbrical, and we can see that one side of the muscle belly arises from the flexor tendon of the middle finger. The opposite side arises from the flexor tendon of the ring finger, sharing one common distal insertion at the extensor aponeurosis. Second, they do not share the same innervation. The first and second lumbricals are innervated by the median nerve. Meanwhile, the third and fourth are innervated by the ulnar nerve. And last, and most important for the purposes of this presentation, they differ in their macroanatomy. The first and second lumbricals are unipainted muscle bellies. Meanwhile, the third and fourth are bipainted muscles. Please remember this because it is key to understanding this pathology. One frequently used position in rock climbing is what is known as the one-finger grip, in which the ring finger is fully extended, bearing most of the body weight. Meanwhile, the remaining fingers are kept in a clenched fist, with their flexor tendons fully flexed. Let's take a look at this diagram, in this case of the fourth lumbrical. And we can see that this one-finger grip results in divergent forces being exerted on each side of the muscle belly. One side being pulled towards the body with the flexor tendons of the fifth finger, and the opposite side being pulled distally with the fully extended tendons of the ring finger, resulting in muscle tearing. And this is why you can only have this type of injury in the third and fourth bipainted lumbrical muscles and not the first two, which are unipainted muscle bellies. Now for my take-home points, you have to be aware of this type of injury in rock climbers, especially once you're looking for pulley injuries, whether or not the pulleys are intact. I've just shown you one of each. And more on the anecdotal side, it really helps to be a better clinician and look at your patients. I perform ultrasound with very dim lights, so when I turn on the lights on my last patient, I could see that he had mild hypothenar ecchymosis. So maybe if I would have seen this, it would have made my diagnosis a lot easier. Then again, if we were better clinicians, we may all not be here. So with that, I will leave you with my social media, where I frequently post MSK-related topics that some of you may find interesting. This is my beautiful hometown, Santiago, during the winter. Once again, very grateful for the invitation, and thank you all for your attention.
Amazing, Juan Pablo. Love it. Thank you.
Thank you.
Hillary, do you have questions for the speakers? I don't see any here in the chat box.
I don't, but I was chatting privately with Graeme about his cases because it was very reminiscent of a case series that I presented quite a while ago, and then the resident never published, what we called Subscapularis. And these were all in adults who turned out to all have subscapularis tendon tear, not all of which were actually visible on MRI, because we are not as sensitive for detecting subscapularis tendon tears on MRI as the other tendons. And radiographically, the only reliable view for seeing that oscal, which always means there's a tear, was only the axillary view, which we don't do routinely. So he pointed that out on his in his series of cases. So I don't know that it really warrants doing an axillary view in every case, but certainly if you have any indication of tenderness over the subscapularis or weakness. I don't see any questions in the chat.
Yeah.
I enjoyed Juan Pablo's case very much. The only case I've seen was a guy for the rescue service that went out during one of our big storms off the coast of the UK here and fell, obviously gripped on with one finger, and developed the same thing, pulley injury with an associated quadriga effect and a tendon injury. But I'm impressed with the ultrasound finding. On MRI, it stands out with the edema and kind of yells at you a bit, and you go and find out what's going on here. But the lumbrical injuries on ultrasound probably takes a bit more sharpness to pick up.
Okay, thank you. So if we don't have any more questions, I will thank you all for tuning in today. The next session will be held on June 30, and we focus on rheumatology. Thank you.
Thanks, everyone.
Have a good weekend.
You too.
Too.
Thanks, everyone. Cheers.